Good evening, everybody. I'm Dr. Yvonne Holt, the Medical Director of Next Bioscience, and I would like to welcome you to the placenta launch of our new exciting product, AmnioRederm. AmnioRederm is a biological wound care dressing made from placental membranes. We're extremely excited about this product as it is completely novel to the South African market. I would now like to introduce you to Dr. Carl Montague, PhD scientist and head of the placenta division of Next Biosciences. Over to you, Carl.
Thank you, Yvonne, and welcome everybody this evening for the launch of AmnioRederm by Placenta. Placenta is a company of Next Biosciences, and Next Biosciences, if you don't already know, is a South African biotech company that combines medicine, science, and technology to create innovative products and services which empower you to invest and take personal ownership of your future health. As well as Placenta, the Next Biosciences group includes Net Cells, which is a private stem cell bank giving individuals the opportunity to collect, process, and bank their stem cells for future potential medical and aesthetic uses. Also within the Next group is Next Genetics, which is the go-to genetic testing company in Africa, which specializes in reproductive genetic health, helping you to build healthy families. Hexa Labs offers a number of health and lifestyle tests in the functional medicine space, allowing you to invest and take ownership of your health. And finally, Next Pathology, which is a molecular pathology laboratory that aims to provide healthcare practitioners and patients with accurate diagnostic and screening solutions to enable better healthcare choices and decisions. But tonight we're going to be talking about Placenta, and Placenta engineers regenerative biological products from the placenta for applications in ophthalmology, wound care, and aesthetics. At the bottom of this slide, you'll see photographs of our facilities in Midrand, and you can see there the clean rooms and the stem cell tank storage facility. Our facility is ISO 13485 accredited, which means that it's accredited according to the medical device manufacturing standards. It's also licensed by the South African Health Products Regulatory Agency for the manufacture of medical devices. And we've been manufacturing medical devices since 2012. The two products that have been on the market since 2012 are called AmnioMatrix and OptiSerum. AmnioMatrix, we've sold over 1,900 units for use in ophthalmic procedures. And OptiSerum, we've sold over 13,000 bottles, and those have been dispensed for the treatment of ocular surface disorders. So the key message is we're not a new company. We've been around for many years, and so we've got a vast amount of experience in the use of placenta and umbilical cord blood for the production of medical products. Turning now to AmnioRederm, our new product. AmnioRederm naturally accelerates wound healing. It reduces the time to healing and provides a greater reduction in wound size than the standard of care. AmnioRederm provides a greater percentage of total wound healing versus standard of care, and it reduces direct and indirect costs of non-healing and chronic wounds. It's very easy to apply, as we'll show you later, and it can be applied as an ambulatory treatment, so it allows people to get on with their lives while they're getting the treatment. AmnioRederm is a specialized adjuvant wound therapy designed to naturally stimulate the recovery of non-healing soft tissue wounds. It's made from human amniotic membrane, which is a collagen-rich structure comprising the innermost layer of fetal membrane of the placenta. And it's been shown to contain significant quantities of bioactive compounds and growth factors associated with the stimulation of wound healing. And in the bottom right corner, you'll see the photograph of the AmnioRederm membrane. AmnioRederm is a potent facilitator of wound healing for several reasons. Firstly, it contains a number of bioactive factors, including collagen, other cell adhesion factors like fibronectin and laminins, and many growth factors, including HGF and TGF-beta. The amnion is also a basement membrane, so it is closely adherent to the epithelial layer, and it acts as a substrate for cellular growth. So when you place the AmnioRederm on the wound, on the ulcer, the patient's own stem cells will migrate to the wound, will become situated onto the AmnioRederm membrane, and then will differentiate and grow into epithelial cells. The properties of AmnioRederm include it's anti-inflammatory, antimicrobial, it has anti-scarring properties, it's anti-angiogenic, it has an anti-pain action, it's non-immunogenic, and it promotes epithelialization. So all of these factors result in a mode of action in which there's high concentrations of cytokines and growth factors. The AmnioRederm covers the inflamed or exposed areas and favorably influences the wound healing. It reduces the level of pain and discomfort. Because it's a natural membrane, it conforms easily to the wound surface, and it's hydrophilic, so it naturally absorbs the surrounding fluids, and although it's dehydrated when it's placed on the wound, it gets rehydrated very quickly. And then it resorbs into the wound itself. You don't need to remove AmnioRederm, it actually just becomes part of the wound healing process. Regarding the raw materials that we use for the product, all of the donors are carefully selected through private hospitals in Gauteng, which are close to our facility in Midrand. Obviously, we get informed consent from all the donors. And once we've got consent from the donor, then we take maternal bloods for infectious disease testing. The tests that we perform are the ones required for any graft, including HIV, hepatitis B and C, HTLV, CMV, and syphilis. Providing all of those results are negative, the placenta is collected and transported to our facility in Midrand for processing. And the final part of the processing procedure is use of gamma irradiation to completely sterilize the product. We then have a final step where we check that the product is sterile by taking samples of the finished product and conducting microbiological testing. And only if the testing is negative for any contaminating bacteria or fungi, then we release the product for sale. The advantage of using placenta is that it's considered medical waste, so it's just normally disposed of within the hospitals. There's no harm to either the mother and the baby by collecting the placenta. And as it's a donation, there's no incentive involved, and so there's no perverse incentives involved in the process. The indications for AmnioRederm include non-healing diabetic ulcers, non-healing venous leg ulcers, pressure ulcers, and partial thickness facial burns. The product specifications, we make the product in only one size, that's 2 centimeters by 3 centimeters, 6 centimeter squared area. The product is dehydrated, can be stored at room temperature, and has an expiry date of 5 years from the date of manufacture. On the bottom of this slide, you'll see pictures of the packaging of the product. So it comes in sterile packaging, and then that can be easily opened. And it's important to remove the biological membrane from this polyester net. The polyester net is just there to make it easier to see and to handle the product, but it's not part of the membrane that should be added to the wound. So once you've separated the polyester net from the AmnioRederm membrane, the membrane can be applied very easily to the wound, and I'll show you a video in a few minutes about how easy that process is. What I'd like to do now is to just take you through some information about the use of AmnioRederm for treatment of diabetic foot ulcers. So I'm sure many of you know that diabetic foot ulcers occur in approximately 15% of patients with diabetes. And of those who develop a diabetic foot ulcer, 6% will be hospitalized due to infection or other ulcer-related complications. Diabetes is the leading cause of non-traumatic lower extremity amputations. Indeed, foot ulceration precedes 85% of diabetes-related amputations. And you'll see on the bottom here some pictures of typical non-healing diabetic foot ulcers. The International Diabetes Federation has provided some stats regarding the prevalence of diabetes in South Africa, and they estimate that the total cases of diabetes in adults in South Africa is around 4.5 million. The prevalence of active diabetic ulcers is approximately 5% of diabetes patients. So at any one time in South Africa, there will be around 5% of 4.5 million patients who have an active ulcer. It's estimated that 15% of diabetic foot ulcers become chronic and do not heal, and that of those, 50% of foot ulcers get infected, of which 20% result in amputations. So there's clearly here an unmet medical need where non-healing diabetic foot ulcers don't heal, they can't be treated, and eventually they lead to amputations. Amniotic membrane is not new to the use of treatment of diabetic foot. Indeed, it's included in the International Diabetes Federation guidelines and recommendations for the treatment of diabetic foot. You can see here a section from the 2017 guidelines under the adjuvant therapy section. Highlighted in the box, it says, item 3, for diabetic foot ulcers that fail to demonstrate improvement, which they define as greater than 50% wound area reduction, after a minimum of 4 weeks of standard wound therapy, they recommend adjunctive wound therapy options. And included within those options is amniotic membrane products. So, you know, this is not globally, this is not a new product. It has been studied intensely. However, this is the first product to be made available on the South African market. This is a meta-analysis of all the clinical trials conducted so far of human amniotic membrane for the treatment of chronic diabetic foot ulcers. It was published this year, so it's very recent. And in the top box there, they say that they have identified 257 articles, of which 7 articles, including 465 clinical trial participants, were included in the meta-analysis. And they say that the proportion of complete wound healing in human amniotic membrane plus standard of care was 3.88 times as high as that in standard care alone. So just adding an amniotic membrane to the standard of care, you're able to get almost 4 times as many patients or ulcers to be completely healed. They also say that the intervention group, those that received the amniotic membrane, had a significantly shorter time to complete healing. So there's very clear evidence here that amniotic membrane has a marked effect on the both the wound healing, the percentage of wounds that are totally healed, plus the speed of which they heal. I'd like to concentrate just on one of the studies in that meta-analysis by Domenico in 2016. They compared dehydrated human amnion versus standard of care in facilitating wound closure in non-healing diabetic foot ulcers. Non-healing, so they hadn't healed within, there hadn't been any healing for at least 4 weeks. And the patients were randomized to either standard of care or amnion plus standard of care, which was applied weekly for up to 12 weeks. So looking at the 2 graphs at the bottom of the slide, on the left-hand side, the graph is the percentage of wound closed over weeks, over time in weeks. And in green, you have the results from the wounds that received just the standard of care. And over 12 weeks, the maximum percentage of wounds that were closed was around 25%. However, when they just added the amniotic membrane to that standard of care, you can see that they get, after 4 weeks, they've got 50% of the wounds are closed. After 6 weeks, it's around 70% of the wounds are closed. And around 9 or 10 weeks, they get up to a maximum of 85% of the wounds closed. So quite dramatic and significant results with the amniotic membrane. On the right-hand side, the graph shows the percentage of the wound area reduction, again in time in weeks. And the green, again, the standard of care. And they see quite quickly a reduction in wound size of 40% within 2 weeks. But they don't really see any further increase. By week 12, they still sat at around 40% reduction in wound area. However, when they use the amniotic membrane, within 2 weeks, they're seeing around 65% reduction in wound area. 4 weeks, it's up to around 80% reduction in wound area. And then after 8 weeks, they're seeing close to 90% reduction in wound area. So these results show that it doesn't work. Adding the amniotic membrane has a massive effect over the standard of care. It doesn't work all the time. There are some patients who seem to be resistant to wound healing using the amniotic membrane, but certainly a very significant effect in terms of percentage of wounds closed, as well as the percentage wound area reduction, the speed of healing. The next study, this study by Zelen et al. In 2014, looks at whether you should apply the product weekly or every other week, bi-weekly. And again, looking at non-infected ulcers of greater than 4 weeks duration. And looking again at this, the graph on the bottom left, you can see that the bi-weekly group with the line with the squares, within 2 weeks, they're seeing 20% of wounds healed. Around 6 weeks, they're seeing 70% of wounds healed. And then around 9 weeks, you're getting up to 80% wound healed. But what's very apparent is that when you use the product weekly, you get a more rapid increase and greater number of wounds that are completely healed. So by 2 weeks, you're getting almost 60% of wounds totally healed. And by 4 weeks, it's up to 90% of wounds healed. And in this study, they actually got up to 100% of wounds healed by week 8 when they used the product weekly. So how should you use AmnioRederm for the treatment of diabetic ulcers? Firstly, cleanse and debride the wound. Place the AmnioRederm over the foot ulcer and ensure the graft covers the entire ulcer surface. Cover the AmnioRederm with a non-adherent dressing. And then just from then on, it's just your standard dressings as you would for standard of care. Examine the wound weekly if possible, and then apply a new AmnioRederm once a week. There's no need to remove the previous AmnioRederm. It gets resorbed into the wound. So you just place the new AmnioRederm on the top. And if no significant healing is observed by week 4, then discontinue the use of AmnioRederm. If you can't see an effect by week 4, then you're unlikely to see an effect. And as I said, it doesn't work all the time. And any infections should be treated as you would per standard of care, either systemic or topical antibiotics. So just to show you how easy it is to apply the product, got this short video. So first you have to separate the membrane from the polyester net, the white polyester net there. As you can see, it's very easy to do within your clinic or your rooms. You just pull it off. And that membrane then is applied to the ulcer. So here's a diabetic foot ulcer that we've been treating with Sister Phoebe Brewer's been treating in her clinic. And you can see the AmnioRederm sticks to the wound. It absorbs the moisture. So it's very easy to apply. And then over the top of that, that dressing, just apply a non-adhesive dressing and then an outer dressing. Moving on to venous leg ulcers. They're the most common type of leg ulcer, accounting for more than 90% of all cases. And venous leg ulcers are estimated to affect around 1 in 500 people, at least this is UK data, although they become more common in age. And it's estimated that around 1 in 50 people over the age of 80 has a venous leg ulcer. Brewer et al. Have published recently in 2020 a study where they looked at Gauteng clinics and the treatment and the healing of venous leg ulcers in Gauteng. And they found that 30% of venous leg ulcers in their study did not heal, and that 17% of venous leg ulcers resulted in amputation. So again, we've got chronic wounds that are resistant to healing and eventually can lead to amputation. This is a study by Serena et al. From 2014, and they were looking at the use of 1 or 2 applications of amniotic membrane for the treatment of venous leg ulcers. So in this study, they had 84 patients enrolled into the study, and they had 3 groups. One group, they had 1 application of amnion at day 0, and then they covered that with multi-layer compression therapy. The second group received 2 applications of amniotic membrane on day 0 and after 2 weeks, again covered with multi-layer compression therapy. And the third group received just the multi-layer compression therapy, which in this case was the standard of care. And then if we look at the figure on the right-hand side to see the results, in green we have the multi-layer compression therapy on its own, the standard of care. And after 4 weeks, we can see that the percent reduction in wound size has maxed out at around 20%. So they see that occurring within 2 weeks, and then they don't see any further reduction in wound size in these patients. However, when they add only 1 amnion to the multi-layer compression therapy and they apply the amnion at day 0, they see a very quick reduction in wound size of 20% in week 1. That increases to 35% in week 2. And by week 4, they've got over 50% reduction in wound size. What was interesting in this study was that when they applied 2 applications of amnion at day 0 and at week 2, they didn't really see any benefit over the single application. So there wouldn't seem to be any clinical reason why you would need to apply 2 applications rather than 1 membrane. Also interesting in this study was that 79.5% of patients in the amnion group reported a reduction in pain, which is obviously a very important outcome in this study. So how could you use AmnioRederm for the treatment of venous leg ulcers? Again, cleanse the ulcer with saline. You can do debridement. In some of the studies they did, in some of the studies they didn't. It seems to be variable. Place the AmnioRederm on the ulcer so that it covers the complete wound area. Cover the AmnioRederm with a non-adherent dressing, and then apply multi-layer compression bandages or compression stockings of level 2 or 3 over the AmnioRederm and the dressing. Only 1 AmnioRederm should be applied at the beginning of the treatment, and that can be left in place for 1 week before you change the dressings again. And then after that, you don't need to remove the AmnioRederm, you just leave it in place, and you can change the outer dressings as you require. For pressure ulcers, which are injuries to the skin and underlying tissue, primarily caused by prolonged pressure on the skin may not be broken at first, but if the pressure ulcer gets worse, it can form an open wound or a blister, which is a category 2 pressure ulcer, or it may develop into a deep wound that reaches the deeper layers of the skin, and that's a category 3 pressure ulcer. And finally, you get the very deep wound that may reach the muscle and bone, which is a category 4 pressure ulcer. Below are some photos of typical pressure ulcers from the studies that we'll be looking at with amnion treatment. In this study from 2017, Degani et al. Took 24 patients with category stage 2 and 3 pressure ulcers. The patients were randomly divided into 2 groups, those that received the amnion and a control group. The amnion treated group received the amniotic membrane to cover the ulcer, and in the control group, they just were treated with a local dilantin powder application. The authors reported early signs of response, such as a decrease in wound discharge by as early as 12 to 14 days after the amnion had been applied. And they only saw complete pressure ulcer healing in the amnion group. They didn't see complete healing in the control group. They did see partial healing in the control group, but the partial healing was significantly higher in the amnion group, and the healing time was much faster in the amnion group than in the control group. 20 days in the amnion treated versus 54 days in the control group. And reassuringly, they reported no major complications with amniotic membrane use. Here's some of the pictures of that study. Figure 2 on the left-hand side shows a patient with a pressure ulcer on the buttocks. A is day 0, at B is day 15, and C is day 30. So there's significant healing by day 15, but by day 30, there's complete healing of the pressure ulcer. On the right-hand side, figure 3 is an ulcer that was located on the greater trochanter. A is day 0, B is day 7, C is day 14, D is day 28, then we have day 32, and finally day 50. So complete healing by day 50, but even by day 14, we're seeing the wound looks much better. How would you use AmnioRederm for treatment of pressure ulcers? It should only be used for stage 2 or 3 pressure ulcers. It's not going to work for stage 4. Clean the pressure ulcers with saline solution. Debride of superficial dead skin with a scalpel. Remove any encrusted exudates by washing with an iodine soap solution. Apply the sterile AmnioRederm on the ulcer bed to cover the entire area, and then leave it uncovered and undisturbed for a few minutes, and then cover it with a moist gauze dressing. If the ulcer is an area that's likely to come into contact with the bed and the amnion might get disturbed, then the ulcer can be protected with a gauze dressing and a balloon ring bandage to stop any pressure on the ulcer. A new AmnioRederm can be applied every 2 to 3 days until complete epithelialization occurs. The final indication is burns. The product or similar products have primarily been used for smaller or facial burns. This study by Piana et al. From 2019 was in pediatric facial burns. In this study, it included 30 patients with a mean age of 3.7 years. They were comparing the amniotic membrane versus cadaver skin, and all patients in both groups healed by postoperative week 2. The mean injury severity scores weren't significantly different between the groups, and they only saw complications in the group that received the cadaver allografts. They didn't see anything in the amniotic membrane group. So their conclusion was that dehydrated amniotic membrane wound dressings are a safe alternative to cadaveric allografts in treating pediatric partial thickness facial burns. There's also been studies, the same group have done studies in adult facial burns as well. This is a case study conducted with our product. It was a 32-year-old man who presented with partial thickness burns to the face. The AmnioRederm was applied to the wound on the forehead, just above that white dressing. And the white dressing is a standard of care dressing that was applied to other areas of the face. Chloromycetin was applied over the membranes, and there was no sepsis of the wounds. What we found was that the wound treated with the AmnioRederm healed by day 3, whereas the wounds treated by the standard of care membrane or dressing healed by day 5. And you can see the results of the healed wounds in the picture on the right-hand side. For treatment of burns, you should debride down to a bleeding viable dermal layer. Apply the AmnioRederm to cover the areas where skin healing is needed. Protect the AmnioRederm with moisture-retaining dressings for several days. And it's important to keep the product moist by applying saline to prevent accidental removal and sloughing of the AmnioRederm. You'll receive an order form if you want to order the product, you can just place an order by sending the completed form to orders@nextbio.co.za. And this is just pricing information. We sell the product in single units, 5 units, or 10 units. And the NAPI codes, you'll receive the NAPI codes for the product. So finally, I'd like to introduce the Placenta sales team. So we've got representatives covering the entire country. Here's their email addresses. And so if you want any more information or you want to inquire about ordering, please don't hesitate to contact the team members in the relevant area. So I'd like to leave it there. Thank you very much for attending the launch, and I'll be happy to take any questions that you might have.
Hi, Carl. So we do have a few questions. The first one is, can AmnioRederm be used for older wounds that have been non-healing for 6 months or to a year?
Okay, good question. So in most of the clinical trials and the clinical data that I presented, they excluded wounds that have been present for more than a year. So I think as the wounds become larger and more chronic and non-healing, then it becomes more difficult for them to heal. And bear in mind that this is a biological product which stimulates the body's own response to wound healing. So if the body's response is really is not responsive to the amnion, and the wound is being prevalent for over a year, then it is less likely to work than a wound that is relatively fresh, so for 4 weeks of non-healing and a smaller wound. So I would say that if possible, it's better to catch the wounds. If you have had 4 weeks without healing with standard of care, then it would be a good option to use AmnioRederm.
Okay, great. Thanks, Carl. And then the next question we have here is, have medical schemes agreed to cover the costs for this?
We are still making applications to the medical schemes for reimbursement. So we've completed the discovery application, but obviously that goes through a process of review. And so at this stage, we haven't fully submitted any of the information that's required to the medical schemes, but we're in the process of doing that.
And then how do you treat burned wounds if it is such a small product?
That's a good question. So obviously this isn't really a product that you would use for large burns or burns that cover the majority of the body. It's really a product that you should consider using for burns where there could be on the face, for example, where the patient could be worried about scarring or cosmetic reasons for using the product. So for smaller burns, chemical burns, or small burns on the face, then I would say that it would be the best use of the product.
And then the next question is this type of product utilized routinely in the US and Europe for the treatment of diabetic foot ulcers and other types of non-healing wounds?
Yeah, so in the US, for example, there are a large number of similar products. The problem is that they're very expensive. So the price in the US of a similar size product is around minimum $500, ranging from $500 to $1,000 so per piece. So our innovation and what we've attempted to do is to reduce the production costs as much as possible to make the product affordable to patients in South Africa that need these kind of products available. So our product is approximately one tenth of the price of the US products. And there are products in Europe and in other parts of the world which are similar also. So within the last 5 5 to 10 years, I think there's been a huge growth in the clinical trial data and also the number of different products that are available.
Then, are there any contraindications or precautions when using AmnioRederm?
So in the product is processed, we use antibiotics we incubate the placental amniotic membrane in antibiotics. So anybody who has an allergy to those antibiotics, then they shouldn't use the product. And that's information of which antibiotics is contained within the product information leaflet. And for wounds where the tissue has actually been damaged, where the cells in the region of the wound have been damaged with, say, radiotherapy, then it's unlikely that this product would work because you require the cells it stimulates the natural response. So if the cells are damaged or non-responsive, then this product might not work.
And I don't think this is so much as a question. I think it's just a comment with regards to the medical aid schemes covering the cost. Discovery tend to seek SA costing data. And then the next question is, you mentioned the wound needs to be covered by placenta. So therefore, would large wounds require multiple pieces?
Yes, so with regards to the size, so in order to keep the cost to a minimum, we are just manufacturing one size product. So for larger wounds, then you would require more units, more pieces, until the wound is reduced to a size where it could be treated by just one piece. The reason that we do that is because we can keep the cost of manufacture low if we're just producing one size. I'm carrying one size piece of stock. If we have to manufacture lots of different sizes, then it just increases the price of manufacturing.
Okay, and then on that, would placenta consider making bigger sizes at any point?
I think we would consider it if depending on the demand and the user requirements. The size of the product that we have is based on the size that's manufactured and sold predominantly in the US, and it would cover the average size diabetic ulcer that they saw in most of the clinical trials. So the objective is to try and get the ulcers when they're quite small and around 4 to 5 weeks of non-healing, and so then you would only need to use 1 or 2 pieces to get complete healing.
Then there's another question here. Is there a diabetic foot ulcer classification that this dressing is appropriate for? Is it even effective in bio-overload, reduction, perfusion? What about normal standard of care?
Good question. I'm not sure about the bio-load. In terms of standard of care, in the clinical studies that I presented and most of the others, the standard of care was primarily debridement of the wounds, and then a dressing. Sometimes it was a compression dressing, also offloading as well in many cases. But I've got no answer. I don't know about the actual classification of the diabetes.
Okay, if antibiotics are being utilized when processing this product, is this not interfering with the autobiological resistance?
I'm sorry, Ali, the sound broke up. I didn't hear the question.
Okay, if antibiotics are being utilized when processing this product, is this not interfering with the antimicrobial resistance?
No, because the product, we're using the antibiotics to completely remove bacteria, and then we're using gamma irradiation to sterilize the product at the end. So I don't think there's any opportunity there for the antibiotics are washed off as well after they've been incubated. So there should be no residual antibiotics left on the product. Although if somebody had an allergy to antibiotics, then we wouldn't want them to use the product. But I don't think there's a chance that this would lead to antibiotic resistance in the way that we process the product.
Carl, if I can just interrupt there. I think the question is asking the membrane has antimicrobial properties, but
Okay.
the antibiotics that we treat the membrane with do not interfere with those antimicrobial properties. So no, the antibiotics are just there to, because this is a human product, and coming from the bird canal, we don't have to treat it to remove those bacteria, but it won't interfere with the actual properties of the membrane. Thanks, Carl. Sorry.
Thanks, Yvonne.
And then why can't placenta be used on a stage 4 pressure injury?
Well, you're welcome to try. There is no data about the effectiveness on a stage 4 pressure ulcer. I think the problem is that if those ulcers get very deep, as you saw, the amniotic membrane, the AmnioRederm is thin. We are looking at making multi-layer products, which would be thicker and maybe would be more effective for multi-layer for deeper wounds. But I just wouldn't like to promise that you'll see the same kind of effects that have been demonstrated in the clinical studies for a very deep wound, which reaches almost to the bone. Those studies haven't been done, so it may work. We would just need to do the studies to evaluate its utility.
The next question is, at what point would you involve a multidisciplinary, such as a wound care center?
So we not sure I understand the question. Are you asking whether we collaborate with multidisciplinary teams, or?
I'm not 100% sure. So if the person who asked that question, if you could just clarify, that would be great. But I'm going to move on to the next question in the meantime. For the use in a more rural area, does the product need to be kept cold, or can it be transported at room temperature?
Yeah, so that's what we try to do, is to make this product as user-friendly as possible. The product that we use in ophthalmology, one of the products is kept frozen, but so we wanted to steer away from that. And this product is dehydrated. It can be stored at room temperature for 5 years, and it can be transported. We just send it in a courier envelope, so it's very easy to transport, and it's very easy to store, and you can store it in your clinic rooms in any setting. So it's very user-friendly in that regard.
Okay, and then I've got some more feedback on that previous question. So at which point would you involve a multidisciplinary, such as getting a team of specialists, dietitians, vascular surgeons, etc., etc. They are a multidisciplinary wound center and have 21 specialist doctors on board to discuss complex wounds. So would you be there for them, is basically the question.
We'd definitely be interested in working with multidisciplinary teams or wound care clinics to look at how best to use this product and when best to use it. So a lot of the data I showed you is from US settings and US wound clinics with different levels of resources and different standard of care. So we would be very interested in collaborating with any groups that could help us understand how best to use this product and how we can give better advice to medical practitioners.
Then we've got one last question here, and excuse me if I'm pronouncing it incorrectly. So, any experience with AmnioRederm and bioderma gangrenosum?
Not yet. We don't have any experience of it yet. We are working with a vascular surgeon who has wants to use the product for treatment of a gangrenous wound on a patient. So we may get some data soon from that patient and the doctor.
Okay, that's it. If anyone else has any more questions, oh, sorry, wait, there's one more. Okay, they've just asked if we just contact them directly. So I will contact you, Penny. And if anyone has any more questions, you can just pop us an email. And you can also visit our website, www.consulta.co.za, and we've got a AmnioRederm page there for you to see all the information that you need. So that's it for questions. Carl, I'm not sure if you have anything else you would like to share.
No, I just thank everybody for attending the launch and for listening to the presentation. And please contact us if you have any questions or you want any more information. I'm very excited about this product and the potential use that it could have for patients with these distressing non-healing ulcers. So we would very much like to work with the medical community to look at how best to use the product.
Great, thank you everybody. That is the end of our presentation.